Jens, thank you very much for the kind introduction. And you've truly put together a whole collection of spine masters today, and especially the last three guys, world-renowned guys in spinal cord injury and pushing those frontiers clearly. So anyway, I cut my talk back. And speaking of fires, which we still have a lot of smoke outside, my laptop computer literally went up in smoke about 2 hours ago. So fortunately, I sent a copy of my talk to Corey, and I was going to make it even shorter than I have. But go to the next slide, please. So you have assigned me a talk about contemporary management of OPLL, which in some respects I can abbreviate that, which I already did, because I think there are some important things that need to be heard. And I think I've learned some new things myself, actually, in doing a lot of research about OPLL. And I think it's going to be a little bit interesting. And then I'm going to take a little bit of latitude and talk about other management of cervical myelopathy, which, like anything else in spine surgery, it has no controversy, right? Yeah, not really. Anyway, next slide, please. I have a lot of disclosures, but none of them conflict with this. I like the couple of them at the bottom. I consult for the Justin Sports Medicine for professional rodeo and professional bull riders in the NFL, which otherwise I have a lot of professional disclosures, but none of them conflict. Next, please. So this is actually a very recent article, which I'm going to ask people to look at that, copy it, and read it, because there's actually not enough written about OPLL and how to manage it, and it's a mysterious disease which I've learned a fair amount as well, not only over the years with experience of taking care of these patients. Los Angeles has a pretty large Asian population, but actually I learned about that as well, and I'm going to talk about it. But some of the different management kind of strategies of, and it comes down to, if the patient needs surgery, how do you do it? You do it from the front or the back, and then there are issues with that. And next slide, please. So what's interesting is that these are just a couple little clips from that paper. And a lot of these people don't develop neurologic symptoms. And when you see them, sometimes they come in for neck pain or something like that. And, if they are not symptomatic, either for neck pain, radiculopathy, myelopathy, they don't need an operation. I mean, that is really an important thing. And looking at some of the progression rates, 4% per year. And it really depends on how you measure some of these things, and looking at it a little bit differently as to what is the cross-sectional area of the spinal canal that's occupied may actually be one of the more important things. We've heard a lot about Asia scoring, but the JOA is probably a little more applicable to patients like this, which are non-acute traumatic spinal cord injury patients. Next, please. I'll skip on from that. Next, please. So what are the recommendations? If the patient doesn't have spastic problems or clumsy hands, and they're a pretty high JOA score, if they have a little bit of numbness, they may last for many, many years. And I followed a lot of patients like that as well in my practice. And prophylactic surgery is probably fraught with more problems. But these people, they don't need surgery until they're clearly myelopathic. But when they are, they need an operation. Okay, they're not going to get better. This is not like somebody that, has a little bit of degenerative spondylosis. And I think it's pretty clear they need an operation when they kind of cross the threshold of the criteria that are really nicely put together in this paper. Next, please. So there is no effective conservative treatment, but in mild cases, there is some new medical technology, which I haven't heard of, called Daedronel. And I don't know if anybody in the audience has, but it's certainly something I've studied long and hard about what other treatments are available for these things. But it's interesting. It inhibits calcification and bone resorption, and these patients clearly have a bony abnormality. In fact, I have one sitting in the hospital that had a big OPLL operation, his cervical spine down to the thoracic, about 5 years ago, and he developed some rapidly progressive problems, and he's basically densely paraparetic, and he's going to have surgery in the next day or two. A guy in his 40s, and it turns out he's Indian, and the East Indian population is where the highest incidence of OPLL exists. It's not the Asian population as we've been thinking. Caucasians about 1%, Asian populations 2 to 4%, and the East Indian population is actually at 5%, which I found that quite interesting. And of course, the patient I'm treating right now in the hospital is East Indian. So next slide, please. So when you're going to operate on these patients, these are a couple of little papers that I've gleaned, and this has been around actually a long time. Sang-Ho Lee is from Korea and well-known surgeon and published a great deal. And there's another surgeon, I believe his name's Hida, who they looked at this double density, and it tells you whether the patients have intradural calcification or not, with a pretty high likelihood of being accurate. So if you see this double density on a lateral view, and this is one of these papers, read the paper. It's really interesting that it's been around for a long time, and I've thought about it, but it probably is a very good one, because what's the big issue about operating on somebody from the front side with OPLL is a CSF leak. I mean, that's the biggest problem that can occur. I have a pretty simple answer for that, actually. If you can't predict it and say, okay, this one's going to be a high risk, I'll do it from the back, of which I advocate a lot. I see if you see somebody for the first time, OPLL, unless there is some compelling reason or you think that it's going to be a safe one, you won't end up with a CSF leak, do it from the back side. Do a laminoplasty. I don't do that many lam fusions. I do a lot more laminoplasties. I used to just do laminectomies, which I actually still believe in as well. But if you get a CSF leak, I mean, a CSF leak is not a catastrophic problem. I mean, the cervical spine, a lot of them you can treat with simply glue and a patch and muscle and things like that. If they ever leak, which I find rare, but if they do, and actually I just had a patient recently, some surgeon who I operated on had not really an OPLL, but had a massive calcified disc and had some abrasion of the dura, and we did some patchwork on it, and by gosh, he leaked. I brought him back, I put a lumbar drain in it, solved the problem in 4 days. So, I think it's a pretty simple answer. And Jens and I have these conversations all the time. What do you do about CSF leaks? And I go, well, CSF leaks are an expected possible outcome of OPLL operation operated on from the front side. And that's why I look at them and say, you know what, if there is something that is not compelling to do it from the front side, I tend to do them from the back. Next slide, please. And keep going from this. That's the Hito paper. What are some of the other radiographic things that, and most all of these are from the Asian literature, is that looking at the K line, which looks at lordosis, is that if you have a big ventral mass and the patient's kyphotic, it probably makes a lot of sense that you're not going to decompress the spinal cord as adequately as you will in a patient that has a lordotic cord. And that's kind of the short story about the K-line assessment and the curvature of these patients. But on the other hand, we all know that people with non-OPLL spinal stenosis, even if they have a straight spine or even if they have a little bit of kyphosis, a posterior decompression is a reasonable operation. So this is a helpful one, though. I like this way of measuring it. Next slide, please. Keep going. Next slide. It's the same. I get to skip these slides because I'm not advancing them myself. So anyway, this whole idea about lordosis, just from a historical perspective, one of my old mentors at UCLA, Rick Batzdorf, had written this paper back in 1988 with his brother, who was a mechanical engineer. And they looked at some of the curvature and whether it was appropriate to do just a plain old laminectomy, because in 1988, we didn't have hardware. I mean, we really didn't have any sophisticated hardware to do posterior instrumentation, and we were just having cervical plates from the front. So anyway, it was an interesting article by Dr. Batzdorf, who in his early 90s is still going to the office every day. Wonderful man. Next slide, please. These are just a couple of the illustrations that point out what they were talking about with curvature, and it does relate to the K-line assessment that's done more recently. Next, please. So I'm going to show just some cases along the way, and I look at this and say, okay, here's a patient with a straight cervical spine, and I'm not going to present a lot of data, but I'm going to present a bunch of cases, which just kind of gives you an idea and say, how do I choose these things? And I don't know whether this patient would qualify as having a double layer or not because of that C, what is it, 4 or 5? That looks like it might be intradural. And the one up above may be. You may open this patient up from the front side and wish you'd never done it. So next slide, please. So here's what I did. And, this patient, I'd operated on him a decade ago and still comes back to me. And what's interesting is that I don't think we have a lot of data about what happens with the progression of the calcific mass that these people have in their spinal canal, which is fairly inadequate data. There's just not much out there because I have a lot of patients like this I've followed for years and they haven't changed too much. So they had to get there at some point, but this guy's a decade out. Next slide. What about cervical spondylotic myelopathy? This is where I'm venturing into a different realm at this point, but a lot of spinal cord dysfunction is due to spondylotic myelopathy, and Michael Failing is a world expert in that, and he's made that a big part of his spinal cord injury career, which he probably ought to be giving this talk actually. But I have a few different views that I always confront Michael with him periodically when I talk to him. Next slide, please. So what happens with spinal stenosis? All of these things we know. They're usually older patients, although some can be congenital and younger. They have gait and hand problems. They can have some myelopathy. They have paresthesias, weakness, and it's very insidious usually, and significant progression, which it seems like all of a sudden these patients tend to rapidly deteriorate. And it's kind of like the patient that I have in the hospital right now, who's a thoracic OPLL, but not a spondylotic myelopathy. Next slide. So where did we get to from where we are today? You got to go back to the 1890s that Sir Victor Horsley did a laminectomy on a patient that was paralyzed, basically. And in a year's time, the patient actually got better. 1892, so long way, obviously. We stand on those who went before us. Next slide, please. Yeah, what are some of the things that we consider about treating these patients? I mean, spinal curvature. I mean, I think we even obsess about this way too much, way too much. Does the patient have neck pain? It's interesting. You see patients like this, and I know this patient well. He had no neck pain, but he had a bad myelopathy. You do a ventral or posterior decompression. I mean, these patients are never unstable. I mean, maybe, and cervical MRI scans, they're done in a supine position. So you have no idea what the real curvature looks like, even if they're straightened out a little bit, because it may be patients protecting themselves from radicular problems. So there's a reason that the patients sometimes, you may have erroneous information based on the MRI scan and what it looks like. So I say is that you should never use an MRI scan for making an assessment of something that's fairly subtle like this case as to what their curvature is. Next slide. So you have lots of choices. We know what they are. Anterior, posterior, people do fusions in most of them. I still do laminectomies in some of the old patients that have stiff old necks. Next slide, please. Is this the right operation? I mean, everybody's going to look at this and say, oh, it's fusion and kyphosis. I go, oh yeah, well, I see lots of these patients that came from years later. But what can you think about this and say, what operation gets you the most for the least? What operation would you want as a surgeon, knowing, what the consequences are of having a single or 2-level or 3-level, and then you're at risk for adjacent segment? Does every patient need an operation? Well, if they have a bad myelopathy, I think that's not the scope of this, but are the operations that we do successful? They may be in the short term, but I think we need to rethink some of the disease processes here and look at some of the things, the curvature of the spinal column. I don't know how important that is, and I know that's going to be really controversial with lots of people, but I'm asking the questions, and very hard questions, and I'm treating a lot of people with that in mind, or not. Next, please. Laminectomy. I mean, should you do a laminectomy in people? Do you need to do a fusion? Let's keep going from this. I think that's just a question. Next slide. We know how to do a laminectomy. How about cervical disc arthroplasty compared to arthrodesis for treatment of myelopathy? Bunch of guys we know from years past. This paper was back in 2008. It was a Prestige and Bryan disc ADRs versus artificial discs, single level, which it's not really testing with too much challenge. 2-year follow-up, and they said they basically had the same outcomes as far as neurologic improvement, which they did. All the patients improved. Next slide. Yeah, what about this patient? What about this patient? 60-year-old guy, he's myelopathic. Go to the next slide, please. Okay, back up for me, would you please, Corey? Okay, here's a patient I operated on, and you can see what I did. And here's what he has. This is his scan 4 years ago, and you look at his C3-4. He's got a little bulging disc. He's got lots of CSF around the back of the cord. And this guy's in pretty bad condition. He's had a couple of falls. Has unstable gait. And I do CTs in every patient I operate on, and especially people that I put ADRs into. But you can see what C5, 6, C6, 7 look like. Go to the next slide, please. He just came in the hospital yesterday, or day before yesterday, and one of my young partners kind of picked up on him, and you look at his MRI scan, and he has new problems at C3-4, and he's myelopathic again. His artificial discs, he's got space behind his cord. We're trying to get a myelogram on him, and he's probably going to get operated on Monday. Now, the question is, what are we going to do? Good question. Does he need something done from the back? Does he need his C3-4 fixed from the front? What is the real picture? Because there's so much artifact here, you can't tell. But I thought this was an incredibly interesting case, and it's contemporary because the guy's contemporary talk, contemporary problem. He's sitting in the hospital today in Los Angeles. So we're waiting for a myelogram. I'm always interested in what the faculty is going to say. Next slide, please. These are cases, here's an OPLL, retired cardiologist on the right. Here's a business guy on the left. I mean, these are stiff old necks. They don't move much. And I do laminectomies in these. I don't fuse them. These two patients had no neck pain. They came in with myelopathy, and I will do a decompression on the backside. I don't even see their facet joints. This whole notion about how much facet joint can you take? I mean, you don't need to take any facet joint to do a laminectomy. I mean, the reality is you don't need to. If you do that, I think you just expose too much. So I don't even see the facet capsules. We just open out to the facet laminar junction. You do a decompression. I use a Midas Rex with a craniotome. If there are multiple levels, I still do laminectomies. Of course, these patients all been worked up with CTs, flexion extension views. But the MRI tells you what the neurology would correlate with. Next, please. Okay, similar case. What do you do? 82-year-old. Do you think this neck moves at all? Look at every one of those discs, okay? They're all collapsed down. Nothing moves. He has no neck pain. He's myelopathic, and do a laminectomy on him. Somebody told him to do a big front back operation. We just did a laminectomy. Next, please. Here's a patient that's been in my practice since 2001. High profile guy in Beverly Hills who's a rabbi. Had a cervical myelopathy. I did a laminoplasty on him. He also had a lot of back problems. He was good for a lot of years. Next, please. I did a laminoplasty. I do side door laminoplasty. It's kind of like the Nakano, second one down on the right side. There's a whole bunch of different laminoplasties, but I thought that was the simplest one that I chose to start doing 25 years ago or longer. And just do the side door laminoplasty. I keep the spinous processes intact, the interspinous ligaments all intact, and it's as minimally invasive as you can get. Next slide, please. And here's what they look like. Sometimes we'll do skip levels. Next slide. So this guy came back to me, and he had some radiculopathy, and you see the axial views. This was 10 years later. He's now 58 years old. I did some posterior lamina foraminotomies on him, and he did okay. A bunch of years. Next slide, please. Then he came back. I actually had it on the other side. I think somehow I lost the slide in here, but the next slide, please. I ended up putting 3 ADRs into him, and he's doing okay, but he has some neck pain. Next slide, please. Okay. Next slide, please. So these are just some of the different techniques of how you can do every single level with a laminoplasty, which I tend to do it more. I used to do some of these skip levels just because they were a fiddly operation, and the better I got at this, the more I instrument every level. Next slide, please. So this is the kind of opening that you can get with the laminoplasty. So you clearly can enlarge the guy's spinal canal tremendously with this side door and with a green stick fracture on the intact side. This guy, we left his C1 too, because C1 is actually a very large space. I mean, it's most people, it's 20 to 25 millimeters in diameter. He had room for a spinal cord, decided to do nothing with that. You can see the date on this scan is back in 2002, and I'm still following the guy. We haven't had to do anything at C2 or C1. Next slide, please. These are just other cases. I can keep going from here. Next slide, please. A little kyphotic, but you know what? Look at his standing cervical x-ray. I mean, taking the pressure off his spinal cord and probably some of his foramen. Multi-level degenerative problems. I mean, I did these a lot of years ago, and that's why I have this collection of them. It's like, this guy does fine. Next slide, please. I don't believe in doing fusions. That's kind of the bottom line here. I look at all these laminoplasties, and I don't do laminoplasties every week, but I can tell you what I do nowadays. I do artificial discs. Pretty much every day I operate, I'm putting artificial discs into people. And a lot of them, older patients with bad degenerative problems like this. Next, please. I'll show you some cases like that. So here's a challenging case. He was recommended front back. Next slide. And I already showed you this case. Next slide, please. Laminoplasty case next. I mean, so this guy ended up with a little bit of a straightened and slightly kyphotic spine. And if he has no symptoms, he's happy and I'm happy. Okay, do we need to make everybody lordotic? I'm not so sure. I think the patient knows better than we do about what the curvature of their neck ought to be. And if he's got some collapsed discs, let him be that way. Guy has no neck pain, leave it alone. Next. Doing big corpectomies, I haven't, unless somebody has an OPLL that I operate on from the front side, I don't do corpectomies, basically ever. I kind of learned that 20 plus years ago. I was asked to be a John McCullough lecturer, the McCullough retractor, and they asked me to come out in Denver and give a talk about cervical myelopathy and when to do corpectomies. And this was a slide that I made about over 20 years ago. I said, I just don't do them. I don't believe in them for multi-level degenerative problems. I mean, you can go do fusions from the front of this guy, but I'd do something from the backside. Next, please. So these papers, there's a whole bunch of them. Zogogawala and, the authors you see. I think that defining the indications for doing surgery in myelopathy, I think have become pretty crystal clear in my mind, and I think they've helped identify these group of patients. Now, how to treat them is a whole different story, at least in my view and opinion. This particular patient, this patient has a congenital narrow spinal canal, and there is some ligamentous hypertrophy in the back and buckling. And the reason I use this slide is this is what they published. Why don't we do artificial discs in a patient like this? I would do a CT scan. I would want to know that if they don't have instability, I'd probably be inclined to put artificial disc into both levels that they operated on. At some point, if they ever needed something done from the back, you can do a laminoplasty. I've done it in reverse. I showed you a case earlier that did a laminoplasty on 20 years ago and then put some artificial discs in. Next slide, please. I'm trying to finish, so let's keep going. Next slide. Next slide. Here's a good joke I always liked. Young surgeons fuse, middle-aged surgeons refuse, and old surgeons refuse. Houdini's final undoing. Next slide, please. Is laminectomy a dead procedure? I don't think so. Let's go past this one. Next slide, please. Next slide, please. I'm going to skip the whole notion is that laminectomy has not been included in some studies that look at different treatment alternatives. And I think it's still an appropriate one. And it's done in older patients with stiff neck and look like they'll be fine with a laminectomy, and they don't all need a fusion, at least in my view. Next, please. I have a case that I'm going to show. In fact, I'm going to skip past this. Next slide, please. Next. It's posterior fusion. Well, that's a whole. Some people do. I mean, pediatric cases with tumors, yes, keep going. Get next slide. Next slide. Adjacent segment. Let's keep going past this because we all know about adjacent segment disease and Alan Hillebrand, and there's been a lot of studies about adjacent segment. Keep going to the next slide. I have a case that I want to show at the very end. Keep going. I'm trying to help us save time too. Back up. I need to, and I'm going to end with this case. This is a 48-year-old interventional cardiologist. He plays basketball. I used to play a lot of basketball, but I didn't play with the same group of guys he did. But he'd had some neck pain for a lot of years, treated conservatively. He was at the gym. He noticed some paresthesias, and he went on to develop a fairly rapid myelopathy. He's treated with some steroids. Next slide. I want to see the scan. Next slide. He has a Hoffman's, tandem gates unstable, and this is his MRI scan. Not a very good looking scan with a big signal change in his cord. And this guy's an interventional cardiologist. He's now unable to conduct his practice. And that's the axial view through C4-5. Next slide, please. And I want to go fairly rapidly through these. Here's C5-6, pretty tight stenosis. Next slide. C6-7 has some bad foraminal problems, and he's got radicular pain. Next slide, please. I want to go through these pretty fast. Flex X, next slide, please. A lot of bad looking discs. Here's the axial at C4-5, axial at 5-6. Next slide. Okay, here is foramen, left side. Next slide. Right side, not as bad. All right, what are your options? Laminectomy, laminoplasty, lam fusion, fusion anterior, laminectomy and fusion, cervical arthroplasty. I wish I were there that I could take a poll, but I'm just showing you what I did in this case. Long talk with this guy. Okay, this case was 6-7 years ago when I saw him and took care of him. And I told him, I said, this is not a normal situation. I've been doing artificial discs in the lumbar spine since 2002, the cervical spine since 2004. The the regulatory process slowed down the use of artificial discs. He wanted artificial discs if at all possible. And I told him, I said, I've done them in some shorter cases, that are pretty straightforward, more like an acute disc herniation, things like that. But keep going. Next slide, please. So here's the answer. Here's what I did. And that's how deep that calcified disc was and osteophytes in his cervical canal at C4-5. Next slide, please. We're going to go rapidly through these. Next. And this is just a procedure. Next. ADR in. Next slide. Next slide. Next slide. Next slide. Next slide. There you go. So there's a story. He went back to work. He's not playing basketball, but he went to playing tennis or back to playing tennis and other things, plays golf. He's an athletic guy. Went home the day after surgery. And as I said, he went back to work eventually in a fairly short time, within a few months. Next slide, please. Next slide. I don't know why we keep going back to that one. Keep going. Next slide. So, cervical myelopathy, we've been treating this same disease ever since surgeons have been operating on him, and myself since the 80s when I was in my training into the early 90s. We have a lot of new treatments. I think the patients benefit from these things, but I would add to that comment, it may be temporary from adjacent segment disease, which I think is a huge problem. I've been in practice so long, I see a lot of patients come back. I see a lot of patients come back that I did, posterior foraminotomies on for radiculopathy. But I see patients come back that had fusions that I did that I regret doing it. And I'd say if they were in my practice today, I would have put a couple artificial discs into them, 1 or 2 or 3. And I think they wouldn't be back with adjacent segment disease. I think some of that data is actually coming out. Matt Gournay has done a lot of work out of St. Louis. We know that fusion creates adjacent segment disease, and it's a fact. Laminectomy is still viable. Laminoplasty, I think, is useful, but I just don't think there are that many patients you can do a laminoplasty in, with the same effect. I do cervical arthroplasties in patients with myelopathy pretty regularly now. I do cervical artificial discs. I will do cases every week. I'm doing artificial disc cases every week, whether it be lumbar or cervical. There's probably not a week that goes by that I'm not doing at least 1, 2, or maybe 3 artificial discs. I think somebody has to push the envelope here, and I've taken that on as I want it to be me. We have a factory at Cedars of a whole bunch of us do this. Probably 3 or 4 guys will do a bunch of ADRs for a lot of different reasons that are outside of the normal box. Next slide, I think, is the end. Thank you very much.
Incredible bandwidth. Thank you for joining us despite extenuating circumstances. Totally agree with so many things. And again, just want to summarize one of your main points. Getting a CT, almost a 0 threshold prior to doing surgery is so important. Thank you, Patrick. Here now is a question. So I think you addressed it partially, but laminoplasty versus a fusion and presence of OPL going posteriorly, clearly a strong preference nowadays. I've just seen too much now going on in both publications in my own practice where the OPLL can progress with continued motion and can kind of, or is more predictably arrested with a posterior fusion. What are your thoughts on that in the big picture? Putting your anecdotal hat on, the big cowboy hat, and your review of your literature.
Well, that's probably the toughest question you could ask me, and I expect it from you, Jens, is that, if the patient is going to live long enough, if a patient's 60, 70 years old, I'll do a laminectomy. If the patient's 40 years old, I think that that's going to push you to do a fusion, because if it does arrest the progression, we don't know that as a fact, unless I'm not up to date with the literature on that. I don't know that a fusion does indeed stop it. I mean, most of these patients have some form of a dish syndrome, ankylosing spondylitis. It's part of a big or it's a skeletal disorder problem. So I'm not sure we have the answer to that, but that is my answer. Younger patients, I'd probably fuse them.
Yeah, that was a terrific talk. You know, I'm doing more and more artificial discs as well. Do you see a big difference? Like, do you use, for example, constrained versus unconstrained, or do you not really kind of, you know, like, let's say if you've got a younger patient, would you use a one manufacturer over the other, or do you kind of just believe that they're all pretty similar?
No, I think there are a lot of very mobile, unconstrained discs that are on the market. And I don't know if I'm supposed to name names or not, but most of them are quite unconstrained. They're very mobile. I do a lot of older people that have bone-on-bone degenerative discs in their cervical spine. I will go in and mobilize the disc. I mobilize the uncovertebral joint. I think it's kind of like knee surgery, although I haven't seen a knee operation since I was an intern, where the soft tissue envelope is mobilized. And I actually have done some surgery on people just to mobilize immobile segments. I mean, they're not fused, but if I can name one name, I'd say I use the Prestige disc in old people because the ball and trough has a hard stop on it. It's about a 2 millimeter, 1.5 millimeters. And I call that the old guy disc. I don't use many discs. You know, I use that one, and then I use a Pro disc for younger patients. I've taken out every disc that's been made because I've seen problems with some of them. Either it's the wrong disc with the wrong mechanics, and I think that's another whole subject. Is the mechanics of artificial discs are something that we know so little, and that we're putting, you know, one or two discs into people and just thinking it's a, you know, it's a one device fits everything. We need a whole selection of artificial discs.
Need to move on. Great topics. A very, very amazing, widespread talk over so many topics and so many vignettes in there. So we thank you, and we definitely want to have you in our artificial disc forum again in the near future, because you have so many different perspectives and very cool cases to go along with it. Stay safe, and hopefully there's no further objects going up in fire and flames. Great to see you.
I'll be there. I'll be there for the fellows meeting and the navigation meeting. 2 more dates before the end of the year.
Thank you. And last, and certainly not least, Dr. Eric Heyman is